All right. Happy Friday, everybody. Welcome to yet another version of RLR. You know what they say, the saying is about like people who always show up a minute or two late, like Prof. Rez. They're of high, high importance. And the people who start the meeting are the very simple. And the two R's, which one is small and which one is capitalized. And I can't wait for him to get here to emphasize this slightly lame joke. But I'm very, very excited today because um we've honestly been waiting for this case from Nidhi for quite a while. I think you submitted it over a month ago, and based on Prof. Raz, I just made a really lame joke that the small R is the R that starts the meeting, and the big boss R is the one that comes 2 minutes late. Hello, I'm tempted to call you Your Highness. Is that okay? Prof. Raz is going strong in the middle of a night shift, but couldn't pass up a Nidhi case. And I think you two have a lot more in common than you might realize because Prof. Rez, Nidhi is deciding to present a case to us in the middle of her primary care clinic day. She's already seen 5 patients. She has a little gap between patients and decided to use that to present a case to us. So we're thrilled to have you. I'll pass the mic for you to say
So,
hi.
dude, why are you still speaking? Let her present so we can get this done.
I'm so excited to be here, you guys. I've been looking forward to presenting this case all month. And so I'm very happy to have this break and be able to present to you all.
Amazing. We're so thrilled to have you. Well, Prof. Rez will tackle the first alcohol, but maybe you can tell us a little bit about yourself before we jump in, Nidhi.
Sure. I'm a second year in internal medicine, part of the Emory family. Started coming to clinical problem solvers because of my senior, Yusuf, who some of you guys probably know. And I'm applying into cardiology at the end of the year and just love education. I think I'm going to end up working mostly in the outpatient in the future.
Amazing. I feel like so many people have been introduced to CP Solver through Yusuf. We're very grateful for them to him for that. And especially grateful for this moment to be able to dive deep into this case. I think Aisha is doing scribing and Ibrahim will be doing the teaching points. So whenever you're all ready, let's rock and roll.
Awesome. I'm very excited to present this case to you all because this is a patient that I actually grew very close to while taking care of her. And so I hope you guys enjoy discussing this case. This is the story of a 20-year-old woman who was recently diagnosed with heart failure from a non-ischemic cause 3 months ago. She's coming back to the emergency room for worsening dyspnea, orthopnea, and emesis. The emesis just started earlier today. Her parents brought her in. They said that she looks very exhausted. She was having some difficulty breathing earlier, and she was given PO Lasix to take from her last hospitalization. So she's been taking that, but they feel like she has more fluid building up on her over the last couple of weeks. And they just feel like she's very tired, and that's why they're bringing her in. I'll pause there.
Well, nice to meet you, Nidhi. Thank you for being here. And I could already tell this is going to be a special case based on how you started the presentation. And it really tells a lot about the quality of the provider presenting. I think, Robbie, I would love for you to add anything to this aliquot, but it seemed like the problem we're dealing with is heart failure. And with heart failure, it's really helpful to categorize it as heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. And the reason that categorization and classification is so helpful is that when we say HFpEF, usually that's part of the metabolic syndrome. So that's someone with hypertension, obesity, they may have MAFLD, sleep apnea. But because this patient is so young, you can't exclude the possibility of HFpEF. Actually, at Johns Hopkins in 2017, I want to sound a little smart, but I was there at the time. They showed that obesity, independent of coronary artery disease, independent of any other risk factor, is a cause of heart failure. In this patient, we'll look at the echocardiogram, but I'm most concerned for heart failure with reduced ejection fraction. And I have to say, when you're thinking of the most common causes of heart failure as a whole, it's going to include valvular disease, hypertension, toxin, arrhythmias, idiopathic, and the most common cause of HFrEF is ischemia. That's why it's so helpful. So when you have HFrEF, really 2/3 of those cases are due to coronary ischemia. And that's why this patient had a coronary angiogram and they diagnosed it as non-ischemic. This non-ischemic bucket, Robbie, is like a very difficult bucket, I think. And there are so many esoteric causes that fall in this bucket. But I'll just give like a broad overview. I won't dive too deeply just yet as we're understanding the problem. And the broad overview is this. When you've ruled out ischemia, you can have arrhythmia, even in a young patient that has a predisposition to arrhythmia that can lead to a cardiomyopathy. And that's why like a Zio patch and evaluating the rhythm is very important. But common arrhythmias include AFib, or if someone has a very high PVC burden, or even a premature atrial contraction, it can lead to cardiomyopathy or a pacemaker. The other bucket to consider in this sort of non-ischemic category is whether there's some kind of exposure to a toxin, like alcohol, like cocaine. This can lead to cardiomyopathy, or a genetic predisposition. And those come in the form of arrhythmogenic right ventricular dysplasia. There's LV compaction. There's different causes of that bucket. And then the final bucket, which I think is one of the most important to really consider, is if there's inflammation of that myocardium. So if you're in the non-ischemic bucket and you think about rhythm, you think about toxins, you think about genetic, you have to think about, is there something that's causing those myocardial cells to be inflamed? And the final comment I'll make is like this worsening orthopnea, this emesis, I'm still okay with blaming the heart failure, because when you have heart failure and you get backup of pressure, you can get congestion of your intestines and all of those organs that can make you feel crummy. I want to just hear Robbie's thoughts to both summarize what I've said and add any additional nuance that he thinks.
Oh, Professor, I have nothing to add, and I would just emphasize that, like, when people say that this is a non-ischemic cardiomyopathy, I think we tend to be overly satisfied by that diagnosis and say, okay, all right, it's non-ischemic cardiomyopathy, let's move on. But I want you to realize that that is no different than saying this is non-iron deficiency anemia. Iron deficiency anemia is the most common cause of anemia in adults. Ischemia is the most common cause of heart failure. If you are happy with the diagnosis of non-iron deficiency anemia, you're prematurely happy. And I think you should be just as happy with the diagnosis of non-ischemic cardiomyopathy. They tell you the same thing. You've ruled out the most common cause. That's it. And that's all we've done here. And so Prof. Rez's journey to emphasize all the other variables is really, really important. Yeah, I don't have anything to add, Prof. Rez. So far we have non-iron deficiency anemia, and we'll see what else we have left to climb.
Awesome. So for the next aliquot, she has a past medical history of a bone marrow transplant at the age of 10. She got it for sickle cell disease, and she's not on any immunosuppression right now. Her sister was the donor, and the only complication is that she has mucocutaneous graft versus host disease, but otherwise has been okay. She has hypertension, which was diagnosed 2 years ago, and several of her clinic visit notes showed that she had hypertensive urgency. And then finally, she has this history of heart failure. It is reduced ejection fraction, 10 to 15%. And I'll give you some more information, but in the next aliquot, we'll kind of go back in time and explore that diagnosis more. Nobody in her family has any history of heart disease. She doesn't smoke, doesn't use alcohol, has not used any drugs, and she's currently in school. Her medications include a beta blocker, ACE inhibitor, PO Lasix. And she was also on a PO dose of steroids that she had received after her diagnosis of heart failure that were stopped 1 month ago. She's on a blood thinner as well for a thrombus that was discovered in her left ventricle at the last visit. And I'll pause.
Oh, this is such a really complicated thing to think about. To imagine a 20-year-old with this degree of burden of healthcare problems and how to navigate that. And I think realizing that it begins at the age of 10 with a bone marrow transplant for sickle cell disease gives us some insight into the severity of what the sickle cell disease might be. And I think that as we start to analyze how this is all relevant to the foreground information, I think we get two interesting pieces of data. The first is, as Prof. Rez emphasized, that she has a history of hypertension, and the overlap of hypertension and heart failure is extensive. The most simplistic connection between heart failure and hypertension is that hypertension causes the heart failure. However, there are many other ways that those inferences can be made. One is through common diseases, so common underlying diseases. And the most common underlying coexisting disease that causes hypertension and heart failure simultaneously is coronary artery disease and atherosclerotic risk factors. So you might draw the arrows between these two conditions directly with hypertension causing heart failure, or to start to explore whether there's something underneath that connects both of them, with atherosclerotic disease being a leading consideration. But when you start to do that, you start to realize that there are many other connections. For example, patients with kidney disease can develop heart failure and can develop hypertension as well. And that's an example of something that's not super common, but very well described. And then you can start to make much more interesting connections between these two conditions. I think the connection between her bone marrow transplant and her heart failure is probably something that exists out there. We've learned about so many complications of bone marrow transplantation. I'm just not aware of how that might affect the heart, except with possibly invoking her underlying disease and connecting sickle cell to heart failure through by virtue of many mechanisms, including pulmonary hypertension from sickle cell disease and iron overload from chronic transfusions in patients with sickle cell disease. I think it's really powerful to hear what her echo is and how low her ejection fraction is. And her low EF probably explains why she developed so much stasis in her left ventricle to cause an LV thrombus. So the background history really is just very deep and very extreme. I would say that we really, really have to explore the one unexplained aspect of it, which is, why did she get hypertensive at such a young age? And why does she develop heart failure at such a young age? Everything else seems pretty well explained, including her LV thrombus, which is probably just a marker of severity rather than any diagnostic specificity so far. Anything else to add, Prof. Rez? All right, can you tell us more, please?
Okay, sure. So we're going to go back in time to the hospitalization that led to her diagnosis of heart failure. So this was 3 months ago. She had come in with similar symptoms of volume overload. When she first came in, she was afebrile and tachycardic. They got a NT pro BNP on her, which was 15,000. She had a normal CBC and CEMP on that admission, and her troponin was also normal. They also got an ESR and CRP, which were both elevated. ESR was 94 and CRP was 123. And they got a slew of other tests, which I'll just put in the chat, including TSH, A1C, lipid panel, viral panels, all of these things to make sure that they didn't miss a non-ischemic cause in this patient. She also had a left heart cath done that admission, which didn't show any ischemia. Her initial EKG when she came in, it showed atrial flutter, but it didn't show any conduction system disease. And a little bit more information on her echocardiogram. It also showed that she had the ejection fraction of 10 to 15%, but also grade 3 diastolic dysfunction and a thrombus, as we had discussed. I'm going to give you a little bit more information and then I will pause. They also got an FDG PET CT for her to evaluate for myocarditis, sarcoidosis, or other infiltrative causes. which showed that she had some patchy inflammation throughout the heart that was not characteristic for myocarditis. She also had an aortic lymph node that had some mild uptake in it. The cardiac MRI showed some enhancement in different places, and they said it was concerning for infiltrative disease. She was given a preliminary diagnosis of cardiac sarcoidosis, and she was started on steroids. After she left the hospital, she actually started feeling much better. And she said, and she had noticed that after taking the steroids, particularly, she felt great. She was able to focus on school again. In between that visit and the one that she's here with now, she had an atrial flutter ablation, and they had rechecked some labs in between. And at that point, her ESR and CRP had returned to normal. And I'll pause there.
Wow. Maybe I'll just comment on the ESR and CRP and like its significance, and then leave the rest for Robbie to pick up. I have to say, when you have a patient who comes in with heart failure or troponin elevation, it's so easy to miss the diagnosis of myocarditis. It's so easy to miss it because we don't often think of it, but there's certain clues that should make you hone into this possibility. And I want to share those clues with the audience because I think it's such an important teaching point. And those clues include the following. If you see a trope elevation and you follow that kinetics of the troponin and it stays persistently elevated, that's very suggestive that there's some continuous irritation of that myocardial cells leading to a constant trope elevation, because it's not going down and everything has a half-life, so there has to be constant irritation. True, if someone has end-stage renal disease, you might not clear the troponin, and that can be another etiology. So if you have a troponin that stays elevated and plateaus off, if you have someone with inflammation and troponin elevation, yes, base rate is someone is septic and has demand ischemia. But if you have such a low EF and you have an ESR and CRP like that, and there is no sepsis, boy, you have to run towards this diagnosis of myocarditis. Why do you have to run? Because when you have this type of EF with myocarditis, this can lead to death unless a prompt diagnosis is made and treatment is initiated. So oftentimes, these patients will get a coronary angiogram because myocarditis can mimic ACS to the T. But these imaging modalities of MRI with gadolinium and the PET-CT, and what it's looking at, when you give the gadolinium and you're seeing enhancement, that's telling you that there's some kind of pathology. If it's within the distribution of the coronary anatomy, then it's most likely coronary artery disease. But if it's patchy, then it's non-coronary artery disease, and it's consistent with myocarditis. The PET-CT is looking for FDG avidity. To land on a diagnosis of cardiac sarcoid, maybe I'll leave that part for Robbie, like to pick up all the loose ends. I just really want to hammer the point of inflammation plus trope elevation. Yes, demand ischemia, sepsis, but if it's stable trope, you got to think about it because you might need an endomyocardial biopsy. You might need high-dose immunosuppression. You need to be so aggressive in the workup and management of such a patient.
Absolutely superb, Prof. Rez. I think that yeah, I think that God, that is such a being able to use that information, the ESR CRP, and trend it and see that it goes away with steroids. And then presumably, just to clarify, Nidhi, before I share something, reflection prompted by Prof. Rez is, were her steroids stopped? And is that a thread that is involved in her returning now, or is she still on them?
That's correct. They were stopped 1 month ago.
Gotcha. Okay, that's very helpful. Yeah, I think the conversation that we can have, there are many pieces to pick up, but the conversation we can have is starting with basic principles about what the role of a structural evaluation for patients with heart failure. And often that simply means, what is the role of echocardiography in patients with heart failure? And there are three fundamental roles. The first is to actually help you confirm that you're on the right track in some instances, with the idea being that if you're not sure the patient has decompensated heart failure, the structural evaluation, including the IVC and other parameters, can help confirm that there are elevated filling pressures. That's one of the most common roles of getting an echo. The second most common is to actually help you figure out what the EF is. As Prof. Rez said, heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, and the whole alphabet soup of things in between are really important for prognosis and management. What's the final goal? The final goal is to see if there's actually a structural cause that can diagnose the heart failure. And common examples of that are patients with aortic stenosis or with pulmonary hypertension or pericardial effusion. And I think here, the main role of this echo is to actually give us a hint that there is a structural cause at play. And what is that structural cause? When you see grade 3 diastolic dysfunction in the context of contrast enhancement on MRI and PET-CT, I think you really have to wonder what is taking up space in the heart, i.e., is there an infiltrative process? And the infiltrative process is often patchy, hence the patchy contrast enhancement, and often impairs diastolic function as it takes up more space in the heart. So in general, what does a structural evaluation help you figure out? It helps you figure out if there's valvular disease. It helps you figure out if there's shunting, a VSD or an ASD. It helps you figure out if you have high output physiology. And then it helps you figure out if you have a restrictive or infiltrative process. And I think that the degree of diastolic dysfunction along with the patchy enhancement has me really worried that this patient has a infiltrative cardiac disease. Now, again, let's anchor ourselves in the basic principles. Role of echo, confirm the diagnosis, PEF versus REF, and then hint at a structural cause. What structural causes? Valves, shunts, high output, restriction. Here, diastolic dysfunction, patchy enhancements are very suggestive of something infiltrating. Now, here's the key concept to understanding, or the key sentence to understanding restrictive or infiltrative disease. You can infiltrate the heart in one of two ways. Either your infiltrative process exists between cells in the connective tissue of the heart, or your infiltrative process causes accumulation of substance inside the cells themselves. Intracellular restrictive physiology or extracellular restrictive physiology. Now, that concept is key. When something accumulates between cells, it tends to dampen the electrocardiographic imprint of the myocardial cells, hence the low QRS voltage that we classically talk about. And the classical disease that we often look for that is AL amyloidosis. Amyloid particles accumulate extracellularly. What is a disease phenotype that causes intracellular ballooning of the cardiac myocytes? Hypertrophic cardiomyopathy, where you have restrictive physiology as a result of accumulation of particles inside the cells, amplifying the electrical signal. So Nidhi, I think what would be really helpful is to have a sense of what her QRS amplitude is. Is her QRS amplitude dampened and reduced? Is it normal or is it high? Do you happen to remember that? I know it's not part of
That's
the
a
data.
great question. It was dampened.
It was dampened. Now that is very, very, very powerful because that suggests that now there is not just restrictive cardiomyopathy, that there is accumulative extracellular material. So what can that material be? Four things. The most famous, amyloid of many types. The most easy to diagnose is myxedema, glycosaminoglycans. In patients with hypothyroidism, they have tiny voltages when it affects their heart. The most morbid, cancer. Many case reports of solid tumors, but usually lymphoma and leukemia infiltrating the heart. And the most common worldwide is fibrosis. Fibrosis from scleroderma, fibrosis from previous radiation, fibrosis from chronic eosinophilic myocarditis, and fibrosis from graft versus host disease. How do we even begin to know what's infiltrating? You can do a basic serological workup like an SPEP, serum free light chains for amyloid. You can get a TSH, which we have already for myxedema. You can survey the body for evidence of cancer, and you can send a basic autoimmune workup. But ultimately, I think the gold standard test is to look at what that extracellular material is with a morbid but important procedure, an endomyocardial biopsy. But where are we at, Prof. Rez? I think we are using one of the tenets of structural evaluation to, I think, zero in on an infiltrative process that seems to be extracellular. And I think where my mind would be is to review both her history um, and to review to review the systemic fingerprint that she might have that might give us a clue. But I think it's hard not to worry about an infiltrative process, and it's hard not to maybe take the risky step of doing a biopsy to really understand what she has. It's premature, but I think that's where the data is starting to nudge us. Any thoughts about that? Or
I absolutely love it. And the question I would be asking myself in real time is how did they arrive at this diagnosis of cardiac sarcoidosis? And truthfully, in someone who's young with an infiltrative cardiomyopathy, this would be one of the top diagnostic considerations. And furthermore, a lot of patients with sarcoid will have cardiac involvement on postmortem autopsy. I think it's 25%, even if there's no clinical evidence. So really what we need to do as non-cardiologists is look at the illness script for cardiac sarcoid and ask the question, how much does the PET-CT, the MRI match up with that hypothesis? Because when you apply the base rate disease of infiltrative and young, and the majority is due to sarcoid, maybe the risk of doing the biopsy outweighs the benefit of empiric steroids and melting away the granulomas of sarcoid that are wreaking havoc on the heart. In this case, Robbie, I think looking at that past medical history is maybe that's when your antenna goes up. Like, this isn't just any previously healthy person. Like, she has a significant past medical history. But in reality, maybe I can just throw it back to you because your illness scripts are so robust. I would be asking like like how confident, like it's everything in medicine is probability based, but how confident are you that that MRI, that PET-CT, it all matches up with cardiac without hyaluradenopathy, was an ACE level sent, was a urine calcium sent, looking for other fingerprints of sarcoid for the cardiac. But I'm just curious from your perspective, like cardiac sarcoid and its diagnosis.
yeah, Prof. Rez, I'm not an expert in the imaging at all, but I would say that I can see a couple of holes with the cardiac sarcoid. The biggest one is not having conduction system disease on the EKG. It's so unusual to have this degree of cardiac sarcoid without evidence of that. And then I think the grade 3 diastolic dysfunction is another counter argument against sarcoid. I think that base rate is always important to keep in mind. But I really view sarcoid as a conduction system disease that then causes heart failure in the vast majority of patients. And to have grade 3 diastolic dysfunction, as far as my understanding of the disease, would be pretty unusual. Um, but I think everything else is certainly a decent argument for it. But I agree with you. I think her past medical history, she's had so much happen to her. Part of diagnosing sarcoid is to make sure that there's nothing else going on. And here I feel like there's so much else going on immunologically that I think you have to, yeah, you have to be cautious of that. All right, Nidhi, tell us more.
Okay. Thank you guys so much. That was a great discussion. And I just want to say, like, even though I've seen this patient, it feels like such a privilege to be able to see you guys dissect this case and add little pearls that maybe we didn't really pick up on the way. So now we're seeing the patient. She's in the emergency department. Her temperature is 100.5. Her heart rate is 110, and her blood pressure is 80/74. She looks very fatigued. She's still responding to questions, but she's just very drowsy. She has crackles in both of her lungs. for her heart exam, her heart sounds are normal. She has JVD bilaterally up to the ears. She has 2+ pitting edema, and she is cold on exam, both in her distal and proximal extremities. For her CBC, shows that she has leukocytosis to 11.5, neutrophilic predominance. There was no lymphocytic or eosinophilic predominance on her differential, and her CMP is normal except for a LFT elevation, ALT of 114 and AST of 47 with a normal alk phos. A troponin level is normal on this admission. She gets a repeat viral panel with extended testing for Coxsackie virus, parvovirus, which is negative, and she gets a workup for infections, including blood cultures, urine cultures, which are both negative. She ends up getting a right heart cath, and it shows that she is in cardiogenic shock. She gets started on medications, including Lasix, and then she gets sent to the cardiac ICU. And this is actually where I first started taking care of this patient when I started the rotation. She has another echocardiogram, which looks similar to the one before. And she had a CTPE, which was negative for PE, didn't show any other systemic signs of sarcoidosis. So at this point, I'm taking care of this patient, and really not much changes over the course of the week and a half that I'm taking care of her. She gets started on inotropes, ends up requiring 2 inotropes, meaning that she's stuck in the ICU without a way out. There was some debate about getting a biopsy for her because their concern was that she has this patchy inflammation. They were kind of worried about getting the biopsy, and they were afraid that they might not get anything and we might not get any results. We ended up deciding that she would eventually need a heart transplant. And so that was the thought, that we're going to push ahead towards her getting a heart transplant, but we needed a little bit more information on what she has because that might influence the results of her transplant. So what we decided to do before getting this biopsy was get some more imaging, but I will pause right there before I give you those results.
Is it my turn?
Oh, I have no idea what that is.
I
I talked a lot last time.
Yeah, I'll just make an important point here that I once took care of a patient who had cardiogenic shock, and their only manifestation was nausea. Their only manifestation. Nausea can be a very, and we sent the lactate and was elevated, and that patient was in cardiogenic shock. So nausea can be a very sinister process when it comes to the heart or when it comes to the sodium and hyponatremia. One really important thing that it took me a while to learn this is that dysfunction of an organ, like new dysfunction of an organ, is much different than decompensation of chronic dysfunction of an organ. Like imagine someone with cirrhosis coming in with hepatic encephalopathy, you wouldn't blink your eyes twice. But imagine a patient who doesn't have a history of cirrhosis and comes in with acute liver failure. Nidhi told us that this patient was being considered for transplant, and it's really important that you know, in someone this young, who's coming in this decompensated, who's in cardiogenic shock, you're not only thinking about inotropes and LVADs and Impalas and stuff that will help the heart push forward, but you're thinking about a transplant. And I think the entire focus of this patient's presentation is on the myocardium, just given the physical exam, given that they're in shock. And there's really no evidence of like a stress-induced cardiomyopathy. And so everything from the prior visitation, it's putting us in that myocardium through this infiltrator process. Honestly, Nidhi, what I would really advocate for this patient is 1 gram of methylprednisolone stat. I looked at their blood pressure, and they could have adrenal insufficiency from prior exposure to the prednisone, so that might be a component of their hypotension. But their fever, yes, like you have to rule out infection, but in someone who is so sick, who you're worried about a transplant, I would have a very low threshold to give her the medication that actually helped her, in the preceding months. And it's so easy for me on this microphone to say, oh, you got to do a biopsy. Like, why wouldn't you? Um, but it seems like we are heading that direction. And I think the repeat imaging that would be helpful would be that PET-CT to see if there's increased FDG avidity, and that MRI with gadolinium to see if there's increased delayed gadolinium enhancement. It's not that you're enhancing more, it's that this infiltration is leading to delay, like the gadolinium is not getting to those areas that are, infiltrated with substance, while that infiltration is metabolically active, so it's increased in FDG avidity on the PET-CT. Love to hear from you, Robbie, but for me, this is cardiogenic shock. I'm like, why can't I give this patient 1 gram of methylprednisolone? Am I missing a tricky infection? I just think the history makes that less likely. But I remember the last time I said that at one of these VMRs, which one was it? Tell me, what infection was it that I said?
It was glomerulonephritis. That was
What was the infection that
I don't remember what the
there was like
infection.
a rip roaring? It was endocarditis or something. I was like, give a gram, ask questions later. So tell me why you wouldn't give a gram,
Oh
man.
no, not at all, Prof. Rez. No, I'm just sitting here and when you said your mic comment, like I'm sitting on the mic, we all, Prof. Rez and I take care of patients in real life and realize that like when you're taking care of a patient like this, you almost have no bandwidth to think. You're just like doing and doing and doing and doing, and it's amazing how much more time and space you have when you're not having to do the right heart cath and think about the real life decisions that the patient has. And for me, I'm just sitting here and bathing in this idea that like, wow. Her heart is completely devastated by whatever's going on, yet there is no hint of disease anywhere else. I mean, think about that. Like the weight of the syndrome is literally destroying her myocardium, but is not doing anything anywhere else. And I find that to be very telling and very interesting. The only exception to that might be you're wondering about the her liver enzymes, but in the context of cardiogenic shock, it's very easy to invoke that passive congestion is causing a phenotype of congestive hepatopathy, especially the magnitude of the LFTs doesn't rise enough to the level of her heart. And so I think whenever you're dealing with disease that's disproportionately affecting the heart. I think all the restrictive cardiomyopathies do that, but I think you probably have to step back and say, are there anything else? Is there anything else that does that? And I think that's where exposures are so key. And let's remember, we don't know the genotype of this person's immunological system anymore. She was transplanted at the age of 10. So I'd be curious, like, what was the source of her transplant? Where did that come from? And is that is that a genetic exposure that's really, really important? Or was that an exposure for potential transmission of infection? And I say that because you have to think about whenever somebody has a fever and devastating heart failure to think about the infection most notorious and most well described to do this, which is Chagas disease. And so you might wonder, like, oh, why would somebody in Atlanta get Chagas disease? And the reason for that might be to really realize that actually it's creeping up there, but also because the person who she got transplanted from may not be from Atlanta. And so I think I'm really stepping back now and being like, we think about genetic all the time. We're asking her family history, but is that really the right question to ask? And we're asking about her geological exposures, but is that really the only geology she's limited to? So I think that's the only other addition that I have is just emphasizing her transplant, what genotype that, what diseases via genes may be transmitted, what diseases via infections may be transmitted, and to remember the effects of medications from her transplant, including, of course, the benefits of steroids, but also the possibility of graft versus host disease affecting the heart in the fibrotic manner that we talked about. And then also, there's a rare association of tacrolimus causing infiltrative cardiomyopathy, but that usually is of the intracellular type where the voltages are high. So I think in addition to surveying the present, I think looking back and seeing the source of her transplant probably might be important.
You didn't answer the main question.
Oh, what was it? Sorry, I forgot.
You give a gram or not?
Would I give a gram or not? I honestly don't know. I think if I had to do it and if I were alone by myself, for sure, there's nothing else to do. But if I'm surrounded by people in real life, I think they'd be way smarter than I am in this circumstance, honestly. So I'd probably be like, where'd you get your transplant from? While they answer that question. Yeah, I wouldn't be able to answer that. Nidhi, what did you guys do?
Well, I have one more aliquot before I get to the steroids question. So her transplant was from her sister and who lives in Atlanta. Um, and then we didn't give her steroids at that time when we first saw her. The thought was like, let's get some repeat imaging and see what's happening in her heart. So a repeat FDG PET scan was done, which showed that those areas of patchy inflammation that she had, they weren't in the same spot anymore. Now they were in a different spot. And so and basically what happened in between is that she had gotten steroids. And then the repeat cardiac MRI showed that she had increased delayed gadolinium enhancement in non-vascular distribution in both the left and right ventricles and also fibrosis. And I forgot to mention that the FDG PET also showed that that aortic node that she had, the aortic lymph node, was enhancing compared to before. But it was so close to the vasculature that we couldn't have anybody biopsy that node. So in the next so then at this point, we talked to hematology and rheumatology. We asked rheum, like, do you guys really think this is cardiac sarcoid? Because we don't think so. And they agreed that this did not fit the typical picture for sarcoid. And we talked to hematology because we were asking them, are you guys considering graft versus host disease in the heart for this patient? And what I learned from them is that, first of all, it's very rare to get cardiac graft versus host disease. And secondly, in the people that do have it, they're usually still on immunosuppression or they were on immunosuppression for a long time. And this patient was only on it for a year and she'd been off of it for 10 years. So they thought it was very unlikely that she had that. So the next aliquot, I will tell you guys the results of a endomyocardial biopsy that we did.
Nidhi, was it a gram of steroids?
We did, no, she just got PO steroids when in the outpatient setting.
Okay, one of these
Yeah.
days, my comment of a gram will end up being true.
Oh, oh my gosh, I don't know what to say. I think yeah, Professor, I would love to kind of chat with you. I don't know what significance to attribute the migratory inflammation, but rather to say like the disease process is active. Um, I don't know what to make of the aortic lymph node, and honestly, part of me is really reducing its significance because it's one lymph node that's close by. Um, yeah, I think I'm really stalling to make progress without seeing exactly what I think is infiltrating her heart. Um, yeah, I just keep hitting roadblocks and I'm not able to make progress. But I think I'll just say it out loud. I'm not sure what the significance of the migratory inflammation is. Maybe it just implies the effects of steroids. And I'm curious what you're doing with the lymph node because my instinct hasn't been trying to amplify it. I've been kind of reducing it, but I'm curious where you are.
You know, I think, Robert, you just highlighted something that's so critical is like just saying out loud a unique finding that I bet you once we learn the final diagnosis like that, migratory, FDG avidity may be key to prioritizing what process may be at play here. So I think it's so important for all of us to just point out stuff that we recognize as unique and not shy away from it, because that might be key to unlocking the diagnosis. But honestly, all I'm doing with the lymph node is I'm putting that in the background and I'm saying I have to explain inflammation of the heart and like of those inflammatory processes, what might also explain an enlarged lymph node and maybe prioritize that ever so slightly, but not exclude any other possibility. I think at this point, honestly, there's no way for me and the knowledge I have to prioritize a specific disease entity. All I can say is that I'm going to be looking for lymphocytes, eosinophils, giant cells, like all those causes, like graft versus host disease, sarcoid, like all those causes we're going to be looking for. And it's just going to be important to recognize that if you miss the site, you may get a negative result, but doesn't mean they have negative pathology. And so these actually, they might do a couple of biopsies to increase the yield of a particular diagnosis. But I can't prioritize anything. What I do think, though, honestly, I think it's something that is treatable with immunosuppression. So I think it has to do with the immune system going haywire, whether it was a virus that now is causing lymphocytic infiltration, or whether it's like the giant cells, usually elderly people, or something related to this transplant that she previously had. That's as far as I just think it's immune dysregulation, not infectious. I don't think it's cancer, though you can never rule out lymphoma, but I think it's immune mediated, Robbie. That's steroid responsive.
Yeah, I know. I completely agree with you. I just wanted to share that. I realized I was trying to find the visual about the restrictive cardiomyopathy earlier, but I had a hard time finding it Evernote. So I'll just share it with you all just to kind of emphasize where we're at. Where is the extra material? I think you look at the QRS. Is the QRS big or small? It seems small. And so is this amyloid? Could be. Is this myxedema? No. Is this cancer? Probably not. Is this fibrosis from radiation, from scleroderma, from graft versus host disease, or sequelae of eosinophilic myocarditis? Either, yeah, these are sub-entities. But yeah, I think I don't know. I think that's where my mind is stuck here. But we'll see. What do you have in store for us, Nidhi?
Okay. So, um, we did do a lymphoma leukemia panel on her, which was negative. And we did end up having to send multiple biopsies because of that patchy infiltration. The biopsy, and as the biopsy result came back, we are doing exactly what you guys were doing, just trying to read online and see what clinical picture fit this patient's case best. The biopsy result came back, which showed lymphocytic infiltration, but no fibrosis. And I will pause there. And for the next aliquot, we ended up sending the biopsy just for a second opinion for this patient, and that will end up revealing the final diagnosis for her.
Maybe I can just quickly share something on RLR, but please don't take a picture of this one, Ibrahim. Let me see. Okay, here we are. This is okay, just really quickly. Rob, sir, this is where I was with this oh, wait a second. This is the wrong one. We're not talking about cancer and calcium. 1 second, guys. I have to do a new share. All right. You see the RLR, it goes deep. Okay. This is where we were. And by the way, it comes with a video. So we'll just watch these 10 minutes real quick. Okay. So at the end of the day, this is probably where I really was. Like, you had ESR CRP inflammation, young patient. We were at myocarditis. And then you have to suspect it. You have to consider the mimickers. And then if they're stable, you can do this. But if it's fulminant, like this patient, it's an endomyocardial biopsy. And then the screening comes like the transplant history, like medications, vaccines, et cetera. But then it's almost like the pathologic DDX. And lymphocytic, I usually associate with viral. I don't know how you feel about that. But could she have been vulnerable to some kind of viral syndrome because of her immunosuppression, sickle cell, that then activated the immune system, that then caused lymphocytic infiltration? But it seems like you were putting weight in that QRS amplitude, and maybe the lack of fibrosis is surprising to you. And I don't know how these affect the QRS amplitude and how sensitive it is. But let me pass the mic to you and stop sharing this screen, unless you guys are in. No, I'm just
Prof. Rez, there are times when you're taking care of a patient or you're figuring out a case and where you just realize like you've really reached the limits of your knowledge. And this case for me has pushed me well beyond my knowledge structure. I'm not sure how to connect with confidence lymphocytic infiltration. So this is a situation where I'm rolling back into the back seat and really, really excited to learn how to connect this. And I agree with you. Could she have a viral process is very, very fair game. I think that wouldn't surprise me. I think the setup here of all these things, it's hard for me to see how it comes together. And I'm really glad for her that for the patient that it seems to come together. And glad that I get to learn that, and glad that you all are here to be able to share that learning. But like I've definitely like I feel like I feel like I how I felt when I was in MS3 with my first ever patient who came in with shortness of breath and a hemoglobin of 11 from his baseline of 13. And my working diagnosis was symptomatic anemia. And my resident was like, no. So Nitty, please, I'll pass the mic to you to tell us what happened.
Sure. So we sent the biopsy to another hospital, and it showed giant cells. And her final diagnosis was giant cell myocarditis that was missed on the initial biopsy. Um, I think all we were kind of surprised by the diagnosis. And what I learned from the cardiologist is usually in cases that they've seen giant cell, the troponin is usually elevated. And so I think that was throwing us off during her diagnostic journey. And the implication of what she had was very important because it would affect her ability to get a transplant or when the transplant would actually be done. Um, this patient actually ended up passing away about a week after I left the rotation. It was she was definitely one of my favorite patients. I had a chance to bond with her and her family while I was on the cardiac ICU taking care of her. And I think it just goes to show that this diagnosis that she had ended up being very severe, and she didn't make it, unfortunately, to the transplant.
Nidhi, so sorry to hear the outcome for your patient. But I appreciate you bringing this to our attention because I promise you, someone listening to this will be primed to diagnose this. And I was just looking at my notes and I realized that histologically, both lymphocytic myocarditis and giant cell myocarditis can present with lymphocytes. And giant cell myocarditis can be easily missed because of the patchy distribution. But I think for me, the age was a little high. Like I just like reviewing my notes, it seems like, but yeah, it could happen at any age. But in any case, thank you for sharing this instructive and educational case. And like my takeaways is if someone's coming in with such a low EF, ask the question, don't land on non-ischemic, like really push forward. If there's inflammation, prioritize myocarditis. And if it's fulminant, have a low threshold to biopsy. And then we showed you the pathological DDX being giant cell, lymphocytic, eosinophilic, and sarcoid. And then sarcoid's a diagnosis of exclusion, but very sad outcome. Robs.
Yeah, I think it's really hard to hear about this, especially I think Nidhi, when you emphasize how many opportunities there were to made the diagnosis earlier, and I think that's got to feel really tough. And I'm curious, really, in our remaining few minutes, just to get your sense of what that felt like for you, what you learned from this case, how you counterbalanced bonding with this person with her complex and really heartbreaking journey.
Yeah, I learned a lot from this case, and I know I feel like I did. While this happened, I was also going to some of the morning reports, and I felt like there was a fingerprint of underlying inflammation in her diagnosis, the leukocytosis, the fever that was going on. I just felt like there was something off with the diagnosis that she had. And it was actually me and my fellow, we kind of had to talk to the attendings. We're like, we really think that she should get a biopsy. I know that it might be tricky in her case, but we don't have a good diagnosis for her, especially if it's going to affect her ability to get a transplant. And so I think like I actually learned that from clinical problem solvers to kind of step back a little bit and see what might be underlying what's going on, like the ESRP, the CRP elevation, it just didn't sit right, even though she had a normal troponin. So we were talking about like multi-system inflammatory diseases, talking about giant cell myocarditis. Like this was something we were talking about every single day on rounds while we were waiting for this biopsy result to come back. So this was just her presentation was amazing, but I think it's really hard when you have a young person in front of you who you want to make a diagnosis for and you want to get better, and then you see that that outcome doesn't always come through. So it was really difficult and it was tough. I always usually like to call the family of my patients that passed away. So I called them a couple weeks after she passed, and it just it was just heartbreaking. But yeah, I'm so glad that I was able to take care of her and be part of her journey. And I'm so glad I was able to share her case with you all, um, so that we could all learn together.
And Nidhi and I think this diagnosis is really rare, especially to make a rare disease in a very rare circumstance of having a bone marrow transplant for sickle cell disease is tough. And even though you set really you're when you're presenting a case like this in this space, I think you're really optimizing the chances of a correct diagnosis because we're not having to everything is kind of like all the data is fed to us in a organized manner, and we're not having to manage the patient. But even then, it's amazing how complex this case was that despite you doing all that, my mind was solving it all wrong. And it was all like, what kind of frame to take? And in retrospect, now I'm looking back at the HPI and realizing that the patient actually didn't have long-standing heart failure, which I think I was kind of subconsciously coding. But the patient went from diagnosis of heart failure to cardiogenic shock in 3 months. And if you frame this as rapidly progressive heart failure, I think that's probably the most helpful frame to adopt in this patient, not so much is it infiltrative or not, because I think the rapidly progressive heart failure bucket is a very, very narrow set of conditions that's really either a massive myocardial infarction, myocarditis, peripartum cardiomyopathy, and the three T's, Takotsubo's, thiamine deficiency, and thyroid storm. And if we had, if I had held that as the guiding frame, forgetting to emphasize just how quickly and deeply she got sick, I think we would be able to essentially latch on to myocarditis um, with great emphasis, and then to say the most fulminant version of it without peripheral eosinophilia is giant cell myocarditis. But I'll add in a little bit of nuance that I would like to share with you all that I'm not sure about. But I think this case, Nidhi, was actually had threads that are very similar to a cardio nerds case that I just listened to 3 days ago, which the diagnosis was giant cell myocarditis, to show you how even though you're trying to learn like I am all the time, you will completely mess up. So this is Cardio Nerds podcast number 359. It's titled Case Report Fee Fi Fo Fum, an unusual case of rapidly progressive heart failure from Georgetown University. And here's the summary, not to spoil it for you, because I kind of did. It was a case of a patient with established cardiac sarcoid, biopsy proven, who then develops fulminant heart failure, who then gets another biopsy and was found to have giant cell myocarditis on that biopsy. And I started to really conceptualize giant cell myocarditis and sarcoid not as distinct diagnoses, but understanding that an acute fulminant version of sarcoid, similar to other acute fulminant versions described in the lungs and the brain and other visceral organs. So I don't know. Did she have sarcoid? Maybe. Did she then develop fulminant myocarditis independent of that diagnosis or as a flare of that diagnosis because she was off steroids? These are all really, really interesting questions, but I really encourage you to check that episode out. It has a lot of threads similar to the ones that you presented today. And even though I had listened to it 3 days ago, it clearly didn't help me today. So I might have to listen to it again. But yeah, any final reflections on your end, Nidhi or Prof. Rez, and we can hear from Ibrahim too.
I think my last reflection is that I think one of the mistakes is separating myocarditis from infiltrative, because if you think, I know you made that distinct point with the clinical diagnosis of like sarcoid and giant cell, but I think it's really hard to distinguish those two categories because there's such overlap. So I think rather than viewing them as separate, like whenever you're thinking of infiltrative, think of myocarditis. Whenever you think of myocarditis, think of it's really overlapping, and with some, that's something that we would love to like, analyze later, Rob, like what are the unique to be able to push us in one direct, but it's really overlap. It's not distinct.
Congrats on joining the Cardio Nerd City. I didn't realize that. That's awesome. Alrighty, Ibrahim, take us home, please.
Well, thank you, Nidhi, for today's case, and thank you to Prof. Rauz and Robbie for the discussion. I tried to actually write as much as I can, but it was a very detailed discussion. So I would suggest to anyone who's watching this or anyone who's attending today to rewatch the episode when it later gets onto YouTube. So the first thing that we've discussed was heart failure. And if a patient comes in with heart failure, you typically want to distinguish the underlying cause for their heart failure. Multiple reasons exist, including coronary artery disease, which is the #1 cause of HFrEF. There's also valvular disease, hypertension, toxins, and arrhythmia. And once you distinguish the underlying cause for this patient, you should then get an echo to typically actually be able to confirm your findings. If you're not able to find an underlying cause, just like our case, you need to think if this was a pre-established heart failure or a new heart failure. If it's a new heart failure and it's rapidly progressive, you need to think about the 3 T's that Rabih has shared with us: Takotsubo, thyroid, thiamine. And then you also want to think about peripartum cardiomyopathy, myocarditis, and large ischemia that can result in heart failure. And then we later heard that this patient had some troponin elevation. And if a patient is coming in with a typical presentation of heart failure, and they also have troponin elevation, you don't want to miss out myocarditis. And the clue in this case would be that the troponin would keep on being persistently elevated despite the time progression. And then for any patient with heart failure, typically the 2 things that one should get would be an EKG as well as an echo. The echo would be able to help you in reaching a diagnosis through 3 of its main elements. Either it could point towards a structural defect, and this could be pointed out using the filling pressure of the heart. And then the ejection fraction would also help you categorize a differential diagnosis for the patient. And finally, it could point towards a structural diagnosis per se. So if a patient, for example, had VSD, shunting, or valvular disease, which could be indicative of diastolic dysfunction and infiltrative cardiomyopathy, just like our patient had. And then on an EKG, the #1 question you want to ask, if it's a low voltage EKG or not. If it was a low voltage EKG, think of the 4 main infiltrative diseases, including amyloid accumulation, myxedema with glycosaminoglycans in thyroid disease, and then cancer, and finally fibrosis. And typically the histology would confirm your final diagnosis, just like we had in our case. And then we later heard on that this patient had overwhelming systemic presentation in addition to their heart failure. And so in that case, you want to think about the exposures that the patient may have had, including infections, medications, as well as the transplant source, since this patient had a prior bone marrow transplant. And finally, when we were discussing the associated lymphadenopathy, we were talking about how it may point towards an underlying immune disease. And so typically you want to get a cell differential, and on the pathology, you want to look if there were any giant cells in your biopsy, since both of these could hint towards lymphocytic and giant cell myocarditis.
Ibrahim, you made us sound smart, though we weren't smart. This is Italian for Rabih. What were you doing? Oh, thanks for cleaning up our mess. Nidhi, thank you so much. Rabih, sign us out, baby.
Through.